right, bon dia. Hello,
Hello,
everybody.
good morning.
Thank you very much to the conference organizers for inviting me to this conference. It's a real honor to be here with you. And today we're going to talk about INSTIs in older adults living with HIV. I have no disclosures, but I do have a disclaimer. In HIV research, the term older adult has been used to describe somebody over the age of 50 years. This is not my definition. And so please understand that when I use this term, it's because of what we use in HIV research. Okay, so some learning objectives that I'll hope to cover over the next 20 minutes. I hope by the end of this talk, you'll be able to describe some common clinical considerations in the care of older adults aging with HIV. You'll be able to name prevalent geriatric syndromes and what I mean by that term, and how that might affect our antiretroviral therapy selection. And then finally, I hope you'll be able to identify some of the knowledge gaps in how we can personalize our ART selection for this important and growing population. In the spirit of the clinical conference, though, I'm going to start with a case, and I'm going to tell you about one of my patients, Mr. D. I'm telling you about him from perspective of a recent clinical visit, but I actually first met Mr. D about 3 years ago. He was diagnosed with HIV in the year 2000, and at the time of our recent visit, virologically, he's been doing well with a suppressed viral load and a strong immune system. When I first met him, before he got started on antiretroviral therapy, he already had a history of hypertension, hyperlipidemia, depression, obesity, and at the time that I met him, he also had acute hepatitis B, which he subsequently cleared. However, over the following 3 years of caring for him, he's developed additional comorbidities. He was diagnosed with diabetes, he'd had a basal cell carcinoma of the skin, and then most recently last year, he had an episode of acute chest pain, which very quickly led to the diagnosis of coronary artery disease, for which he underwent a bypass surgery. And at our current visit, we spoke a lot about his osteoarthritis of his hip, and he had an upcoming surgery for a hip replacement in the coming weeks. A little bit more about Mr. D. He had been working as a truck driver, but had to stop last year after his heart surgery. He lives on a farm with his partner. He doesn't smoke, he doesn't drink alcohol, but he's lost multiple friends and family over the last 2 years and notes that some of his depression has worsened. In total, Mr. D is on 18 different medications. For his HIV, he's on the combination pill that Dr. Gandhi just mentioned, bictegravir, TAF, and FTC. And then with his comorbidities, he's accumulated numerous additional medications. And so the question for us to think about in this talk is the bictegravir, TAF, FTC the optimal treatment for his HIV in the setting of his comorbidities? Okay, so our outline, I'll go through briefly some of the epidemiologic trends related to lifespan, but also health span in adults aging with HIV. We'll talk about ART considerations in the setting of multimorbidity, as demonstrated by my patient. And then finally, what that means for geriatric syndromes and what we still need to uncover. So it's no secret that thanks to the success of antiretroviral therapy, people living with HIV are living longer, and they're living nearly as long as individuals without HIV. And that means in our clinics, we're seeing a growing number of older adults living with HIV. In the US, it's projected that by 2030, which is not that far away, 20% of individuals living with HIV are going to be over the age of 65. This trend of a growing population of older adults with HIV is happening around the world. And again, this is good news. This is improvement in lifespan. In a study led by colleagues a few years ago using the CASINet data, we looked at the trend in the proportion of individuals in cohorts across Latin America of adults who are over the age of 50. And again, we see a trend towards a growing number of older adults living with HIV. So we're seeing improvements in lifespan, but what about health span? So this is an important study that came out a couple years ago from the US, from the Kaiser Permanente closed healthcare network. And in this study, they looked at both lifespan, number of years expected to live beyond the age of 21, but also health span, the number of years expected to live free of a major comorbidity, such as cardiovascular disease, kidney disease, liver disease, et cetera. And they compared in their population individuals without HIV and individuals with HIV, matched on important sociodemographic covariates. And what they found, first looking at health span, or lifespan, when you look at the number of years of life expected to live beyond the age of 21 from the year 2000 to 2016, that gap in lifespan between individuals with HIV and without HIV has narrowed to the point where it was only 3 years by the end of the study period. This is great news. The story for health span, the number of years expected to remain free of a major comorbidity, that story's different. We're now looking at years of free of a major comorbidity. Individuals without HIV compared to individuals with HIV are expected to have 16 more years without a major comorbidity. And compared to the trend in lifespan, this gap between individuals with and without HIV has remained the same over time. So indeed, we know that people living with HIV experience an excess risk of a number of non-communicable diseases or comorbidities, including cancers, cardiovascular disease, metabolic disorders, renal disease, liver disease. But what I also want to emphasize is that it's not just an individual risk of these particular NCDs, but a cumulative effect where individuals with HIV are experiencing a higher burden of multimorbidity or having 2 or more of these conditions, and this multimorbidity is coming on at a younger age compared to their uninfected peers. We're also seeing a growing trend of multimorbidity in adults aging with HIV in Brazil. This was a study that was conducted in collaboration of CASINET and a Ministry of Health existing cohort of individuals starting on antiretroviral therapy from sites across the country. And we found in this population where we looked at NCD events or non-communicable diseases and comorbidities, we found that in this population of about 5,000 individuals on ART, that as the population aged, as the proportion of individuals in the cohort was increasingly over the age of 50, as shown in the black bars, the number of individuals with newly multimorbidity, with 2 or more NCDs or 3 or more NCDs, rose along with that aging population. So why is it that individuals with HIV experience higher rates of NCDs and comorbidities? And we know that these conditions, cardiovascular disease, cancers, liver disease, metabolic disease, often have similar risk factors and similar pathways towards development. We know that there are important contributions by things like BMI and weight, as well as age and sex. We also know that co-infections such as chronic hepatitis viruses, CMV, also chronic conditions like depression can contribute to risk of these NCD events. In people living with HIV, even successfully treated, there's ongoing and lasting effects related to the immune system and inflammation that contribute to the risk of a number of these NCDs. We also know, importantly, that exposure to antiretroviral therapy, especially some of our older therapies, some of the D drugs, as well as protease inhibitors, tenofovir related to osteoporosis, contribute to risk of these non-infectious complications. And then, importantly, and what can't be underemphasized, is the role of social determinants of health in impacting these non-infectious outcomes. So experiences related to discrimination, racism, poverty, exposure to tobacco, alcohol, pollution can all come together over one's lifetime to put one at risk for some of these infections, some of these conditions. And now what we see in people living with HIV, we also have to consider the biologic processes of aging as this population is reaching older years of life. So when we're thinking about our patients with multimorbidity, and you're thinking about my patient, Mr. D, it's often not in the context of just one comorbidity. We're thinking about this in the context of multiple comorbidities. And we start to have this map where we're weighing the relative benefits and risks of multiple different types of antiretroviral therapy, which have different risk profiles depending on the comorbidity of interest. But we really have to think about all of these comorbidities in the context of each other when we're choosing a antiretroviral therapy in combination. You'll note on this slide, I have the box for the integrase inhibitors and cardiovascular disease risk a little bit lighter. And I'm going to go into a little bit more detail some of the studies that Dr. Gandhi just mentioned related to cardiovascular disease and integrase inhibitors next. So this is really a tale of two cohorts. And so I'll first unpack a little bit that first study that raised some question about whether or not integrase inhibitors were associated with increased risk of cardiovascular disease. So this study is from the RESPOND cohort, which is a multi-cohort observational study located in Europe and Australia. And in their analysis, they included 30,000 INSTI-naive people living with HIV who enrolled in care after 2012. They looked at incident cardiovascular disease events, including MI, also stroke, and cardiovascular procedure. And what they looked at was a cumulative exposure of INSTIs. So comparing individuals with no INSTI exposure, comparing then those with 0 to 6 months of exposure, 6 to 12 months, 12 to 24, or greater than 24 months exposure. And here's their fancy statistics and all of the things that they adjusted for. So overall, they had a population of, again, approximately 30,000 individuals, 748 of whom had an incident cardiovascular disease event. And what they found is when they looked at the association of integrase, cumulative integrase strand inhibitor exposure and the incident NCD event, they found that compared to individuals with no INSTI exposure, those with 0 to 6, 6 to 12, and 12 to 24 months had a higher risk of a cardiovascular event. And those are the results that are highlighted there in the orange box. However, they also found that people who were ART experienced and ART naive, but had higher risk scores of cardiovascular disease. So individuals who already had other risks for cardiovascular disease, they were the ones who were more likely to be prescribed the INSTIs. So they performed some additional sensitivity analyses, and ultimately some of their associations were weaker when they started to disentangle who was actually being prescribed the INSTIs versus not. And ultimately, they couldn't exclude the possibility that there was confounding contributing to their results of the association. So in follow-up to that study, we now have the Swiss cohort study, which was the results that were presented at CROI earlier this year. Prospective observational cohort study of people living with HIV in Switzerland. Smaller cohort of approximately about 5,300 adults who were now ART naive, so no prior ART exposure, who were enrolled after 2008 and followed until cardiovascular disease event, death, or loss to follow-up. They used the same cardiovascular disease event definitions as the RESPOND cohort. And here they compared individuals based upon their first ART regimen, individuals who were started on a regimen with an INSTI or those who were started on ART with a regimen that did not include an INSTI. And here's their fancy statistics. They used a different statistical approach than the prior group, and I'll leave it at that, but the details are there if you're interested. So overall, they had 116 individuals who had an incident cardiovascular disease event. And as you can see on these cumulative incidence curves, in the unadjusted analysis, comparing individuals who were randomized to INSTIs in the blue, not randomized, those who received INSTIs in the blue versus those who were started on an ART without an integrase inhibitor in the red, there was an increased risk of cardiovascular disease events over time. However, when they adjusted for things like calendar year, age, sex, prior cardiovascular disease, hypertension, hyperlipidemia, a number of other conditions, actually that risk was not only reduced, but actually reversed and no longer statistically significant. So they concluded that there was no difference among ART naive people living with HIV, no difference in short or long-term risk of cardiovascular disease based upon starting ART with an INSTI versus not. And they did some additional analyses looking at subgroups, looking at differences by sex or by age, whether or not individuals received a Bacavir or not. And again, the results were very consistent. So this calmed a lot of people's concerns about cardiovascular disease and integrase inhibitors. But I'll say that there's still ongoing work and some questions that remain. So shifting gears, we've talked about multimorbidity and the accumulation of NCDs, but we also know that in aging adults living with HIV, and particularly those with multimorbidity, they're also at higher risk for a number of geriatric syndromes or conditions that we associate with much later in life. these conditions such as frailty or cognitive decline often occur at younger ages. Our older adults often experience higher rates of polypharmacy, higher healthcare utilization, decreased measures of quality of life, and increased risk of hospitalization. And I think I've highlighted some of that in my story of Mr. D. When thinking about ART in the context of these geriatric syndromes, I think some of us in adult medicine need to take a page from our pediatric colleagues in thinking about ART exposures from a life course perspective. And this means considering not just what someone's on at an older age, but what have they been on? What have they experienced in terms of ART exposure over possibly many decades worth of therapy? Importantly, what I don't want to lose is the point that antiretroviral therapy is protective against frailty among older adults with HIV. We know that low CD4 count and HIV viremia itself are major risk factors for frailty. So our concerns about antiretroviral therapy and long-term effects really need to be taken into consideration, that we know the importance of antiretroviral therapy in protecting against these conditions as well. In fact, some studies have shown that longer duration of ART, even after adjusting for CD4 and age, is also protective for frailty. But what about certain ARTs? Not all antiretrovirals are created equal. And we're starting to learn more about how exposure to particular antiretrovirals may impact one's long-term risk of some of these geriatric conditions. This was a study that came out of the ACTG HALO cohort, which is following long-term outcomes of people on antiretroviral therapy. And they found that individuals who had prior exposure to efavirenz compared to a PI had a higher risk of frailty, and that difference was not seen in individuals with prior exposure to INSTIs. They also observed that individuals with prior exposure to didanosine or stavudine, medicines that we know have lasting toxic effects on mitochondrial function and perhaps could contribute to sarcopenia. These individuals also were also noted to have lower gait speed. So again, thinking about how prior exposure could contribute to function much later in life. Importantly, though, there have been no randomized control studies that have identified what the ideal antiretroviral therapy regimen should be for adults aging with HIV specifically. A little more to think about is we know that older adults living with HIV generally have higher rates of virologic suppression, and they have higher rates of antiretroviral adherence in general. And we've observed this in a study that we performed in CASINET looking at rates of virologic failure and ART switch. However, what we don't know and what we need to learn more about is how does the presence of some of these geriatric syndromes impact ART outcomes in older adults with HIV. And there was a study that was published using claims data from the US Medicare population, whose average age was about 60 years, and they looked at, based upon medication refills, what individuals were likely not adherent to their antiretroviral therapy based upon late or missed medication refills. And what they found was that individuals who were frail compared to individuals who weren't frail were more likely to possibly have antiretroviral therapy non-adherence based upon medication fill patterns. Interestingly, individuals with polypharmacy, so those who had multiple medications, actually had a lower risk of ART non-adherence. And there was some suggestion that depression was also associated with ART non-adherence. So more is definitely needed. There are some concerns and limitations to these types of data, but we really need to understand how presence of geriatric syndromes impact ART adherence and ART outcomes in this growing population. So coming back to my patient and our question, is bictegravir TAF FTC an optimal regimen for this patient? So I'll put up here what my tallies were as I was going through his comorbidities and considerations, some things that perhaps we're not sure whether or not this is the best regimen or not, and others that I think probably weigh in benefit of having him on his current regimen. One question is given his history of cleared hepatitis B and in light of his polypharmacy, does he really need the TAF? Could that potentially help with some of his weight questions? Or could he be simplified even further from a 3-drug regimen to a 2-drug regimen? So certainly happy to discuss this if there's time. So final conclusions, older adults with HIV are increasingly becoming the majority of our adult patients. Improvement in lifespan have occurred, but we have more work to do to improve health span. The burden and causes of NCDs and geriatric syndromes are complex and include long-term effects of HIV virus itself, antiretroviral therapy, and social determinants of health. And in the setting of multimorbidity and choosing antiretroviral therapy, it's really a matter of weighing these risks and benefits. We need more information to understand how ART intersects with geriatric syndromes, and I think we're going to need to use new models of research, including life course perspectives. We need to have studies that identify the optimal regimens with or at highest risk of these geriatric syndromes. And I just would like to underscore that collaborative research around the globe can lay the groundwork for this to be done. And here I just highlight some friends and colleagues, many of whom are in Brazil and in the room where we have ongoing work to answer questions around aging. So thank you very much.